I'm Danielle. I'm one of the diabetes nurse educators at 61 Queen. I work in outpatient diabetes management. Nice to meet everyone and see some of you here today. If you have any questions while I'm presenting, please ask them. I love when we have questions while we're chatting, just so I get to address anything that might be on your mind. And we'll have some time at the end too for questions as well. Today I'm going to be talking about self-monitoring of blood glucose, so checking our blood sugars, why we might be doing these things, what information do we learn when we test our blood sugars, and really just to have a conversation around diabetes, how it relates to our kidneys, and what we can do with the information we learn from self-monitoring of blood glucose. So it might not be applicable to everyone in this room, but it's a good conversation to start having around diabetes and its relationship to our kidney health. Is the sound okay for everyone? Too soft? Can everyone hear? Good? Okay. So I've kind of just outlined this, but essentially by the end of today, we'll talk a little bit about diabetes, type 2 diabetes in particular, the relationship between diabetes and our kidneys or chronic kidney disease, diabetes self-monitoring, so blood glucose monitoring, how and when to check, what the results might mean. So what does diabetes mean when it comes to statistics in Canada, and why is it relevant for us here today? So diabetes impacts millions of individuals globally, but Canada specific, in 2015, it impacted around 3.4 million people, so about 9.3% of the population. We predict that by the year 2025, around 5 million individuals will be impacted with diabetes. This includes type 1 diabetes and type 2 diabetes. So it's not just a statistic for type 2 diabetes. I didn't include in here that there are also around, in 2015, 5 million individuals diagnosed with pre-diabetes. So that's kind of has a relationship to the type 2 diabetes category in terms of our risk for developing type 2 diabetes. So something to be aware of and mindful of as well. I thought this was interesting. It was published by Toronto Public Health, but it actually looks at diabetes in different parts of Toronto. So it takes a look at the prevalence of diabetes in certain kind of areas within the city. And if we notice St. Mike's, I guess if we had to put ourselves, where are we? Kind of around here. So just around that particular area, we notice that there's a higher prevalence of diabetes. And what does that mean for our diabetes care and planning and strategies around management of diabetes? I don't have the 2018 stats because we're just wrapping up our 2018 year, and this was a 2017 Toronto Public Health analysis. So what is diabetes? I guess that's kind of our important to know when we're talking about diabetes and self-monitoring of blood glucose. So if we just think about diabetes, it's essentially our body doesn't know how to use sugar effectively. That's kind of how I can break it down. It's a metabolic disorder where there's high blood sugar, hyperglycemia, because either we're not secreting enough insulin, the insulin doesn't work properly, or both, if I kind of simplify this. So essentially, we've got impairment of insulin secretion, our pancreas isn't pushing out a lot of insulin, the insulin isn't working very well, or both of those things. When we think about how this impacts our diabetes management, we'll talk about this a little bit later when we come to having a bit more of a chat around testing blood sugars and the importance of this. So just to go back, for diabetes, approximately 10% of the population is living with type 1 diabetes and 90% of the population with type 2 diabetes. Does anyone have any questions so far? So I want you to think about the following. Imagine you're going down a hallway or into this room. There's a door, There's a lock, and there's either a key or no key. If you have the key, do you think you can get into the door? Probably yes. If you don't have the key, what's the solution? Okay, that is a solution, absolutely. Okay, we can do that in the body. What I'm trying to highlight is in diabetes, I like to think about insulin like a key. So when we have insulin around, it's able to open up our cells to sugar. When we eat food, carbohydrate foods, those foods are turned into sugar in the body, which we use as energy. Insulin is that key that helps unlock the cells so that we can use up that sugar. When we talk about breaking down the door, that's kind of an interesting conversation to have, because if we don't have the key, how are we going to get the sugar into the cells? We're not going to be able to, right? It's just the insulin isn't doing the job it needs to do, or maybe we just don't have enough keys available to open up the cells to use as energy. So think of insulin like a key. Our bodies cannot open the cells without it, or we need to maybe think about other ways to help make the insulin we do have open that lock. Sometimes if we put the key in the door, it's the right key, but the door doesn't open, what would we do in real life? Aside breaking down the door. Locksmith, okay, they might rejig the lock, or they might put a little bit of grease. So sometimes we just need help to get that key to work properly. And we're going to talk about this a little bit more. We think about that concept like insulin resistance. So our bodies are still making insulin, it's just not able to use that insulin effectively, which is kind of like putting the lock in the door, but not able to open it up. So let's start here. When we don't have diabetes, what happens? When we eat our foods, those are turned into carbohydrate foods, those are turned into sugar and made available in the body through the bloodstream. Insulin is released from the pancreas, so insulin is that key, okay, at the right time and in the right amounts so that our body can use up that sugar. So in this little picture, we see the G's are the glucose, the sugar. You also see keys. That's the insulin. And we notice that there's some locks, and the keys are actually helping to open the locks so that the sugar moves from the bloodstream into the cells to use as energy. So this is what happens in someone without diabetes. So what about what happens in someone who's living with diabetes? So we have a few different things to talk about. Insulin production from the pancreas is affected. So there's not enough insulin for the body to use, not enough keys, okay? Look, there's a lot more G's here than there are keys. So we're not able to move that sugar into the cells because we just don't have enough insulin around. And insulin isn't working properly. Insulin resistance, okay? That's what that kind of concept is called. It makes it harder for the insulin to work and for our cells to take up that glucose, that sugar. So if we had a bunch of people in a hallway and we only had a few keys, each key meant one person could go through a door, but we had more people than keys in the hallway, what would be the end result after people open the doors? Would there be more people in the hallway or more people in the rooms? In the hallway, right? Okay, this is the same thing in the bloodstream. If we don't have enough keys to open up those cells, where does that sugar stay? In the blood. Okay, so if we're checking our sugars, what might we presume to see? Higher blood sugar, right? You guys are very smart. Okay, so take a look here. These little X's are showing that we don't have as many keys, and we have keys that are unable to open up those locks. And the end result is that we've got excess sugar in the bloodstream, okay? So if there's no insulin, it means that none of that energy is going into our tissues to use. So let's put it all together. Why is this important and why is it relevant? So these two little pictures here show a blood vessel, one with a kind of average amount of sugar in the blood vessel, and one where there's a larger amount of sugar in the blood vessel. So there's more stuff there. But why is it important that we know kind of how much sugar is in our bloodstream? Why does it matter? So we know that with prolonged and chronic high blood sugars, hyperglycemia of diabetes, it's associated with very specific long-term complications that can impact our small blood vessels and our big blood vessels. So small blood vessels can include things like the blood vessels for our nerves, our eyes, and our kidneys. And the big blood vessels can increase our risk for cardiovascular disease. So we'll talk about it a little bit more, but I like to show this picture because it highlights the different areas of our body where diabetes can have an impact. If we think about it, our blood vessels are kind of like a highway. So when we've got more stuff on that highway, more sugar, it's actually traveling to all the different areas of our body. And that's the impact on our vessels, our small vessels, eyes, kidneys, our nerves. It can include erectile dysfunction, and our large blood vessels, thinking about our cardiovascular health, so our heart health, peripheral vascular disease, our circulation, and risk for stroke. So this is just, we'll talk a little bit about the different areas of the body, and then we'll spend some time talking about the kidneys and then about monitoring our blood sugars. So like I mentioned, blood sugars and elevated blood sugars can impact the blood vessels in your eyes. It can cause damage to the blood vessels. You can also see an increase in pressure of the eyes. So the really important thing that we talk about when we're thinking about diabetes management is checking in with your healthcare team, whether or not that's your family provider, family care provider, your diabetes educator, your kidney specialist, and touching upon these things when it comes to our health. One thing I reinforce is always having a conversation with your primary care provider or healthcare team around how often you should be going for eye screenings. Based on Diabetes Canada recommendations, we would go for an eye screening every 1 to 2 years, or as necessary by our kind of eye specialist. These eye screenings are actually covered if you do have diabetes by OHIP, which is important to know. Neuropathy. Has anyone ever heard about that numbness, tingling, pins and needles feeling of diabetes? Some people might talk about that as a sign and symptom of high blood sugar or something they notice over time. So if we think about our blood vessels, they're also supplying our nerves with the energy and nutrients that they need. And so over time, diabetes can also impact our nervous system. And damage these nerves. Some people might experience what we call kind of a sock and a glove presentation of neuropathy. So you can have those pins and needle feelings in your fingers and your feet. Usually they happen in both. So you would have them in both hands and both feet. One thing we really reinforce, just like the eyes, is are you going for regular screening? So we really emphasize the feet when it comes to diabetes management, because for many of us, they're our primary mode of transportation. It's what gets us to and from our appointments, doing our activities of daily living. And so we want to take care of those things and be mindful to screen for any neuropathy, any changes to sensation. So one thing that we do in diabetes appointments is we'll regularly assess sensation with either a monofilament test. So it's where your diabetes educator or diabetes specialist might actually take a little filament, it looks like fishing line almost, and touch it to the bottom of your feet and assess if you're able to feel it. They might also use a tuning fork, and they'll kind of bang it and put it on your big toe and see if you're able to notice the changes to sensation there. This is something that we should have done every year. Erectile dysfunction. So it actually impacts about 34 to 54% of adult men with diabetes. So oftentimes people will come into appointments and maybe be apprehensive about sharing this information with their healthcare provider, but it's actually an important conversation to have because it can negatively impact quality of life. So it's really important to, if you notice any changes, to talk to your educator team, your care provider, about these changes that you may notice. Again, erectile dysfunction can be related to changes to nerves and blood vessel supplies as a result of high glucose. And there are treatment options, so it's important to have this conversation. Nephropathy. So this is our conversation around kidney health and diabetes. Diabetes is currently the leading cause of kidney disease in Canada. Significant changes to our renal function aren't usually seen until later in the course of diabetic nephropathy, so changes to the kidneys based on diabetes. Dialysis may be needed or is needed when kidney function falls below a certain threshold. That being said, the progression of renal damage in diabetes can be slowed, and we can actually prevent progression to nephropathy, thinking about the following. So how do we help reduce our risk of complications or delay progressions? One of those pieces is assessing our glycemic control. So what does the evidence tell us? What's important in terms of managing diabetes and thinking about where our blood sugar should be? Does anyone have any questions so far? Okay, I'll keep going. So there is good evidence to show that in improving our blood sugar control or glycemic control, it can help reduce our risk of both microvascular, so tiny blood vessels, and cardiovascular complications. So how do we know this? We studied, there's two major trials that we did a number of years ago, the DCCP trial and the United Kingdom's prospective trial, so the UKPDS. We studied diabetes in two distinct populations, type 1 diabetes and type 2 diabetes. And what we found was that in improving glycemic control or in improving blood sugars, this significantly helped reduce the risk of tiny blood vessel complications. But it was interesting to show that in the initial studies, there was no significant cardiovascular benefit or outcomes. When they continued to study these populations, so they extended the trials, they actually found that there was significant microvascular benefit, so persistent benefit to our tiny blood vessels. And there was also evidence to suggest that there was cardiovascular outcomes based on good blood sugar control. So when they initially studied the populations, we saw benefit for tiny blood vessels, not the big blood vessels, but when we followed these patients over a period of time, we showed prolonged and continued benefit to tiny blood vessels, and we also started to see some potential benefit from cardiovascular health or heart health perspective. So what was the magic number kind of thing? And this is something we talk about all the time in diabetes. What are our targets for glycemic control? Where should we be? One big one that you might have heard of is this test called the A1C, and we're going to talk about it a little bit more. It's kind of our gold standard of diagnostics in diabetes management, or one of those pieces of diabetes management. And they found that in having an A1C of 7% or lower is where we kind of reaped the benefit in terms of reducing our risk of diabetes-related complications. Okay, but A1C is like something we do once in a blue moon. What relevance does it have for me? It's the test my doctor does every once in a while. Why is it important? Does anyone know what A1C is or what it stands for? Sometimes we call it, I hear AIC. The little one is tricky. It looks like an eye. Essentially what it is, this is a picture of our red blood cells. So when we go to the lab and we have this A1C done, they're taking a sample from the lab. You actually have to go to the lab and have it done. You can't do it at home, although there are some home kits you can use, but I won't go there. So these are the ones you would have done in the lab. And essentially what it's looking at is it's looking at how much sugar is stuck to the red blood cells. Now, red blood cells live on average for about 180 days. They're always turning over and changing. So we kind of consider our A1C, or glycated hemoglobin, like a 3-month average of blood sugar. Now, one thing to note though actually is that for the A1C, what will most strongly predict what our result is the month or so before we go and have the test done. So about 50% of what's important for that A1C in determining what it is happening that month before we go in for that blood work. That's not to say that it isn't capturing or giving us an idea of what that 3-month control is. So again, it's looking at how much sugar is stuck to those red blood cells. From a perspective of how often we do the test, usually it's something done every 3 to 6 months. This really depends on kind of what we're aiming to achieve with our blood sugar control. So maybe if we're looking at making changes to our medication, I keep knocking this over. Sorry, if we're looking at making changes to our medication, we might want to monitor the effect or impact of that every 3 months. If we're very stable in terms of our blood sugar control, we might actually be able to extend how often we do the test to every 6 months. So this is a conversation that your kind of primary care provider, when they are assessing your A1C, they will be having this conversation with you. One thing to be mindful of, and something we're always thinking about, is what are some factors that can actually impact your A1C? So there are some other kind of, let's say, factors, without having to use the word again, other things that can impact what our A1C is. So there are some things that will make it higher. Thanks. Some things that can actually make it falsely high, and some things that can make it falsely low. And so if we know that, then why are we doing this test? Or what is the relevance for us? And that's where I put A1C. So A1C is still our gold standard, even if there might be factors that are impacting it. But how do we fill in the picture? One thing I always like to talk about is A1C doesn't directly mean that this is what my blood sugar is. So patients will often come in to see me and they'll say, my A1C is 8, that means my average sugar is 8. And I'll say, you're pretty close, but it's not quite. So it actually means something a little bit different. So we have to take our A1C and think about it from a different perspective. So to bring it back home, if we're doing self-monitoring, what does my A1C mean to me? So it's kind of, you can take a look at it here. So essentially, I'm just going to do this. So our gold standard is kind of 7. So if we find 7% A1C here, if you look and see there, it's actually saying that the average blood sugar is 8.6. Is anyone surprised by that, or what do you think? For an A1C of 7. A little bit different than what we maybe thought, right? If we take a look, let's say an A1C of 10%. Our average blood sugar would be about 13.4. Now, I say average because blood sugars can be variable and fluctuate. So, you know, we can think of someone having an A1C of 7%. And if they're testing at home, their blood sugar is always being between this kind of narrow range. But with averages as well, we can also have very high numbers and low numbers. And if we put those two together, they can actually average out to the same as the person who has blood sugars who are very kind of consistent. So what I like to stress from this is what's really important. What's important for us to be able to do at home so that we can kind of see what's happening in our day-to-day. I'll let you think about that for a minute. All right, So if we go back to our A1C of 7%, that average blood sugar of 8.6, where does our self-monitoring of blood glucose come into play? If you are checking your blood sugars, there are different kind of target values that we may have. On average, our blood sugar, if we're checking it before a meal, okay, fasting or before a meal, our target is usually less than 7, between 4 and 7. If we're eating, do you think it's normal for our blood sugar to go up? 100%. Even for a person without diabetes, our blood sugar will rise after we eat. With diabetes, we actually expect our blood sugar to rise about 2 to 3 points. And we'll talk more about the specifics of testing in a minute. But this, I just want to give you a general overview of what our targets for blood sugar management are. So 2 hours after eating, we anticipate that our blood sugar will rise about 2 to 3 points, which is why after a meal, our blood sugar targets are between 5 and 10. Now, these are general targets. It's important to remember that all of these things can be individualized to our own needs, okay? And that's in having a conversation with your healthcare team. This is where we pick our targets for blood sugar control. But for the general population, this is kind of what we think about. So as you can see, there's kind of this narrow band that we're aiming for. And sometimes our blood sugars will be higher than that, and sometimes they will be lower. And it's about how we manage those instances when our blood sugar is a bit high or low. That's kind of the work of diabetes management. So if our blood sugars are low, we probably don't want that to happen too often. Has anyone ever experienced a low blood sugar or had someone talk to you about what a low blood sugar is? What might you feel, or what might that person feel if they have diabetes and dizzy? Okay, dizzy, what else? It could be the dead of winter and you're just dripping sweat. Okay, cold sweat is another one that people often describe. What else? Pardon? No energy. Yep. You're feeling like you're just like dragging your feet. Anything else?
You can hardly see.
Yeah, your vision might be impacted. It could be blurry.
Yeah.
So all of these things, that sweaty feeling, shaky, disorientation, dizziness, blurry vision, all of these things can actually be a bit nerve-wracking too, right, when we're experiencing them, because we don't really know what's going on. We sometimes say we're not playing with a full deck of cards when our blood sugar is low. And what I mean by that is that our brain isn't getting the energy it needs. Our brain really likes to work and run on glucose, and so when that level drops, we just don't feel well. It's sending us these signs and signals that something is wrong and we need to do something about it. Other ones that, that people find too, and some that we kind of discredit, is just feeling hungry. So let's say, you've had your breakfast, maybe you're using insulin as part of your diabetes management, and it's now 10 o'clock and you're like, I just ate, but I feel like I need to eat the kitchen fridge. You might want to check your blood sugar because maybe you're low. And so we often discredit that feeling of hunger and just saying, I'm that person who needs to have all these snacks. Maybe it's our blood sugar. So something to think about. Okay, what do we do if our blood sugar is low? Does anyone have an idea? Drinking Coke. Okay. Maybe from a kidney perspective, not the dark colas. I think that's fair to say. Candies? Hard candies, okay. I heard the mention of pudding. We're going to talk about it a little bit because it's actually really important. And when we are going low, like I said, sometimes we can just be really hungry and we want to eat everything in front of us. Probably not the best idea. Maybe ultimately effective, but we might end up with some other numbers at the end when we finished eating the fridge. Hopefully not the actual fridge, because that won't do very much. So before we talk about that, what can cause low blood sugars? So what's an obvious one that maybe, or that we can think about at least contributing to low blood sugars? Yeah, if we're using insulin as part of our management. It's very dependent on how much insulin we took, when we last took our insulin, if we're using insulin as part of our management. Yeah, if maybe we've eaten a different amount of food this day, but we took the same amount of insulin. Or maybe we happened to skip a meal. What's the impact of that? Alcohol can actually contribute to low blood sugars as well. What about activity or exercise? If we're moving, our muscles are using up that sugar, so that can potentially contribute to low blood sugars as well. Interestingly, a lot of people don't consider certain types of housework as exercise, but we have some patients who vacuum and they can go low. So you have to think about if you're scrubbing the floors, right? You have to think about these types of things that you might do as part of your daily life that can impact your risk of low blood sugar. So always something to kind of keep in the back of our mind. One thing when we talk about kind of our kidney population and diabetes is that we actually might need to adjust our medications, things like insulin or some of our oral tablets, as they might contribute to low blood sugars as well based on our kidney function. So these are all important things to discuss with your healthcare team. It's also important to let them know how often you're having low blood sugars. So is it something that happens once a month? Is it something that's never happened? Is it something that's happening 3 or 4 times a week? It's really important to know the frequency because we want to make sure we're able to change something about what's happening in your day-to-day so that you're not having to have all of these symptoms of low blood sugar, potentially dangerous outcomes, but just improving quality of life based on the fact that you're not having to treat all these low blood sugars all the time. So I mentioned this briefly. If our kidney function changes, they might not be able to filter or clear the medications the same way. And so some of those diabetes medications that we use as part of our management might actually hang around a little bit longer. And so they're exerting their effect a little bit longer, and that can cause or contribute to low blood sugars as well. So we might need to adjust our medications. These includes things like our sulfonylureas. So if anyone's using things like dimicron, glyburide, metformin, we will adjust in times when our kidney function is changing, and then insulin as well. So the important thing to know is, yes, we need to be able to recognize low blood sugars, but what do we do about it? So this is where we maybe move away from eating the kitchen fridge and being really mindful about how we treat our low blood sugars. So the general rule of thumb is if your blood sugar is less than 4, it's low. What do we do about it? For most people, using about 15 grams of fast-acting sugar is the way to go. What I mean by fast-acting sugar is something other than food, because when we are low, we just want to eat whatever is there. So we might see the tasty sandwich we've prepared for lunch, and we might want to just have that. Or we see maybe that chocolate bar at the grocery store because we are low while we're groceries, we're pushing the cart. Okay, we just want to have the chocolate bar. Here's the thing. If we use something other than a fast-acting sugar, it actually takes time to be digested and broken down by the body, which means that your blood sugar can continue to drop before we actually bring it back up. The reason why it's so important to use that fast sugar is we don't want your sugar to keep going low, because if there is not enough sugar, the end result is you can pass out. So we want to prevent this from happening. So that's why we need to use something fast. So I heard the mention of things like some sodas or pops, using things like sugar tablets. There's ones you can get at the pharmacy. They come in big tubs. You can use 4 of those to treat a low blood sugar or blood sugar less than 4. But in general, we just want something that's going to work quickly. The amount is important too, though, because if we use too much, what do you think will happen? You will go up fast and you will go up high. So, some people think, do I need to use a really big bottle of soda? You actually only need to use about 3/4 of a cup. So this proves challenging when pop, for instance, is sold in specific sizes or cans. I actually don't know anyone who measures or takes out their 3/4 cup measurer and measures 3/4 of a cup of pop. But ideally you want to use around 15 grams of carbohydrate. If you're in a pinch, things like sugar packets, so 3 or 4 of those that you would put into your coffee, not the sweetener, but the actual sugar packets, can be used to treat a low blood sugar. Yep, honey, about a tablespoon of honey. So here's the thing, cookies though, they actually take time to digest in the body. So instead of using a cookie first, we can try using something fast. And then once we've had about 15 minutes, we're hoping our sugar has come back up. We're gonna check again to confirm that it has. And then if it's back up above that 4, then we can put something into our belly, a little bit of carbohydrate, a little bit of protein, or your next meal. So that prevents you from going low again during the day. So we're actually just going to put something in, a little bit of carbohydrate that will break down slowly over time so that we reduce our risk of having another low later on. We've treated it adequately. If you're lower than 2.8, we actually need even more glucose. So it's not a terribly greater amount. It's not like 2 cups of pop or things like that, but it's about 20 grams of fast-acting carbohydrate. So in case anyone can hear, it's about using maybe a half a piece or a piece of bread and some jam. And so I would say to make sure that we don't keep going low, I would use something a little bit quicker. So even though we, sometimes think that bread digests very quickly in the system, it still has to break down. Whereas if we take something like juice, it's already in a liquid form, it's easily absorbed by the body. So we want to use that first so we don't have another dip before we rise. So if anyone's a driver, there's a few other things that we have to know as well around low blood sugars and driving. So diabetes and using certain diabetes medications doesn't mean that you can't drive. You can absolutely drive. But there are certain things to think about, including we need to be testing our blood sugar and checking where we are at before we get behind the wheel. So our general rule of thumb is to check before we go out and drive, and we want to be at least 5 to drive. So that's our rule, 5 to drive. And actually, we have a number of resources from the library as well today around how to treat low blood sugar and driving. So all this information is available to you as well. So our general rule of thumb, 5 to drive. So what if you're 4.3? What do we do? Drive? No drive. Okay, no drive. But you have somewhere you need to go. So what are you going to do? Call a taxi. Okay, I am not a millionaire, so I cannot call a taxi. I like the sound of this. So you've kind of got it right. So we want to bring our blood sugar back up so we can do the thing we need to do. So the suggestion is have a snack, have something to eat that's going to turn into sugar in the body, some carbohydrate, bring your sugar above 5 and get on with your day. The one thing that we really need to think about when we're driving is if we start to have symptoms of a low blood sugar. So let's say we're driving, we're on our way to somewhere, an appointment, whatnot. We start to feel, what are we going to feel again? Those signs and symptoms of low blood sugar? Dizzy, heart racing, shaky, sweaty. Okay, we're feeling all of those things. We're going to we stop the car, we pull over, we get out our kit, we check our sugar. Oh, we see it's 3.5. Do you think we continue on the road? I'm glad everyone had the right answer. So the answer was no. Okay, but that doesn't mean we can't get on our way. It means that we need to stop, treat our low blood sugar, whether it's with our 15 grams of carbohydrate or our 20 grams, depending on where our blood sugar is, fast-acting carbs, retesting our blood sugar again 15 minutes later. Oh, it's come back up. Are you good to go at that point? Yeah. Okay, it was a bit of a trick question. So you're not actually good to go just yet. The rule is you have to wait about 45 minutes before driving again, and that's to ensure that our blood sugar does not continue to dip before we get behind the wheel. So we are operating a heavy piece of equipment or machinery when we're driving, and so that's to ensure our own safety and the safety of others on the road. So we've talked a lot about low blood sugars, but what about the other end, when our blood sugars are high? So what does hyperglycemia or high blood sugar look like? So we all have kind of a different, I think, idea of what elevated blood sugars are. Sometimes people will come in and say, my blood sugar is always 8, it's really high. And oftentimes people will come in and say, my blood sugar is 15, what do I do about this? So where are we kind of aiming when we're thinking about what is high blood sugar? So if we're testing our blood sugars first thing in the morning or before a meal, and they are consistently above 7, then technically that would meet criteria for being high at that time of the day. After eating, if our blood sugar rises above 10, technically that would be high for that time of day after a meal. So what do we do about it, or what are some of the reasons why our blood sugar might be above our targets? But first, what might we feel if our blood sugars are high? I guess I've kind of given you the answer before I asked you the question. So you might feel changes to your vision as well, similar to low blood sugars. You might be very thirsty or have a dry mouth. You can be very tired, fatigued. You can almost feel like, oh, you need to sleep even though you may have just gotten a good rest. And again, this darn hunger. Sometimes the signs and symptoms of high and low blood sugar can look the same. So what do you think it's important to do then, to be able to tell the difference between a high and a low? Because we're going to treat them very differently. Checking our sugar. So this is really important. Okay, so what might cause high blood sugar? Maybe it's we missed our medication, that can happen, or we're not on the right dose. Maybe we've eaten a larger meal that day, more carbohydrate foods that have turned into sugar. Maybe we're under a lot of stress. This can impact our blood sugar control as well. We might be sick. One thing to think about in terms of our kidneys is that certain dialysates or dialysis fluids can actually impact our blood sugar control as well. So this might mean that we need to change our medications or our medication management. What I'm trying to point out is that there's not just one reason why our blood sugar might be high or low. There's all these factors that actually impact our glycemic control and what happens to our blood sugar. And you guys have already answered the question in terms of how do we know where we're at? How do we know what's important to us when it comes to our blood sugar control? And we need to check our sugars. So that's where self-monitoring or using a glucometer actually becomes really handy. Many years ago, the only way we had to assess blood sugar was actually using urine dipsticks. So you'd have to pee, dip the little stick, and you'd pick on a band the different colors to see where your blood sugar was at. Okay, that's really not great for promoting hand hygiene. Okay, nowadays, we actually have much different means of checking our blood sugar. We've got these nifty little devices called glucometers that have actually evolved even over the last few decades. So we used to have these big machines. They required this big drop of blood, big sample. You had to wipe a strip, do all this time processing. Now you can stick one in your pocket, pull out the strip, lance your finger, and you've got your number. It's become much more convenient from a user perspective, from an individual having to test their blood sugar. It's a lot simpler. That doesn't mean it's still not work, right? There's still steps involved in checking our blood sugar. The nice thing about checking our blood sugars is that we can actually do it at home. So we don't have to go into the lab to do it. It's not like an A1C. You can conveniently check your blood sugar at home. You can bring that piece of technology with you when you're out and about so that you have a better idea of where you're at during your day. A lot of educators talk about self-monitoring kind of like a GPS or the speed control on your car. So imagine you had a car, we've had cars for a long time without GPS, but imagine you had a car without a speed control. So nothing to even tell you how fast or slow you're going. How do you think you're going to be able to drive? How you feel? Yep. How we feel might not always be a good representation of what's actually happening. It gives us our first kind of clue or indication. But it's almost like putting a blindfold on and getting behind the wheel a little bit. Yeah, we want to know what we're experiencing. What your experience is too can be helpful. But we really think of our self-monitoring as a tool to help us fill in what's happening in our day. So what does it involve? Has anyone seen any of the kind of self-monitoring devices that are currently available in Canada? Mm-hmm. Yeah. Yes, that's a hot topic conversation. Can I touch upon that in a second? Okay, so the conventional way of checking blood sugar involves a blood sample. So we have many different kind of companies in Canada that are currently manufacturing glucometers, as we call them. At the end of the day, they're very similar in terms of how they work and what they do and the pieces involved in testing. So there's always some type of machine or device that interprets the blood sample and converts it into a number that we can think about in terms of our targets for diabetes, so millimoles per liter. You don't have to remember that. You can just think 4 or 5, 6, 20, whatever. There's a lancing device. So that's actually what's going to poke your finger. There has to be some kind of poke to get the blood sample to be able to apply that to a test strip. Oftentimes, there's a lot of apprehension around self-monitoring because it does involve a poke. But we'll talk about some strategies that will hopefully help reduce or make finger poking a little bit more comfortable. Really, having a conversation with your healthcare team about what might be an appropriate device to use for self-monitoring is a conversation you can have, because while all of the devices essentially do the same thing, we might want one that has a bigger screen or a brighter display, or one that actually talks to us. Maybe we don't, or we have challenges in seeing the screen. We might want something that's more auditory. So these are important questions or conversations to have with your team about choosing a device that's right for you. We might also want ones where the strips are less pliable, where they bend less. They're easier to manipulate. So something to think about when we're selecting an appropriate meter to use on a day-to-day basis, because it has to be something that that doesn't provide barriers or challenges in terms of testing your blood sugar. It has to be easy enough to use. One thing to consider for our dialysis patients is that certain dialysates or solutions and some meters don't actually work well together. So based on the solution and how the meter assesses the sugar, they're not compatible. So it's important to have a conversation with your provider about finding a meter that is going to provide you accurate information. How do we check our sugar? So I'll walk you through kind of a step-by-step guide. These are the nuts and bolts of self-monitoring blood sugar. So the first thing I suggest is prepare all of your supplies. because sometimes, when we're in the midst of things, we've got our lancing device over here, we've got our test strips over there, we've already poked our finger, where's our strip? And then we're leaving a little trail of blood along the floor, or we've poked our finger and we don't want to poke it again and our test strip isn't ready. So these are all things to kind of have at your disposal when you're ready to test. Washing our hands. It might sound very simple, but let's say we've just eaten a piece of fruit, like an orange or whatever it might be, and we feel that our hands are clean. We don't notice anything sticky on them, and we don't visibly see that they're soiled, and we go to check our sugar, and it's 25. When normally you've never seen a number like this, and all of a sudden you're on the phone and you're calling us and you're like, my sugar's 25, what do I do? And I say, did you check or make sure that your hands are clean? Because you might not see anything on your fingers, but that residue from that fruit you just ate is contributing to a false high on your meter. Okay, so washing our hands is very important. I always say, put that test strip into the machine before we poke our finger. Because again, if we poke our finger and the test strip isn't there, it's a bit of a disaster. The other thing to make testing a little bit more comfortable is making sure you're using the right type of lancing device, or it's set at the right depth. So each company makes a different type of device, but all of them have the ability to change depths in terms of how deep that little needle is going to go to poke your finger. So if you're someone who's just starting to test, your fingers are likely not very calloused, and you're not going to want to use depth 5 or depth 7 to poke your finger, because then you're going to come back to me and you're going to say, this is really painful, I don't want to do this, and I just don't feel comfortable continuing. And my response might be, did we check the depth of the lancing device? Because maybe our depth needs to be adjusted. And also, how often are you changing that little needle? So usually they come in about boxes of 100, the lancets. Again, each company makes their own. Best practice would have me tell you that you need to change your needle after every use. This isn't always realistic, because maybe we're having to check our sugar multiple times a day. So if you're using that lancing device for the day and you've checked your sugar maybe 2 or 3 times, that would be okay. But those needles are designed to be really fine and to poke our finger. So the more you use them, the duller they become, the more it hurts. The other thing in terms of making testing more comfortable, and I'll get you to do this with me, is if you can put your hands together like this, touch the pads of your fingers. Okay, and take a look at the areas that are touching. So that's right where all of our there's more nerve endings. So those pads of our fingers, the parts that are touching, those are going to be the parts, even though they look nice and juicy and ready for a test, okay, those are the parts that are going to be more sensitive. So if we're aiming to test around the edges of our fingers, that can hopefully help reduce the sensation when we're poking our finger. So once we've poked, we apply the blood to the test strip. Each strip will have a different area to apply. Some of them are on the sides. Some of them are on the front of the strip and suck it up like a straw. So it's important before we actually apply the blood to know where the blood is going. And then that prevents us from being frustrated when we're going to do our test and the meter is not providing us a value because we haven't applied the blood in the correct area of the test strip. So I've just shown you a sampling of some of the meters that are available in Canada. To touch on the one comment from one of the ladies was about flash monitoring. And I know Tess, one of the nurse practitioners who spoke last month, talked a little bit about flash glucose monitoring. It's something new that's available in Canada. It no longer requires finger poking, but it's not currently covered by our Ontario formulary. So I won't spend too much time talking about it, but there is information online to kind of review and look into if that's of interest. Flash glucose monitoring, if anyone's interested in looking that up. So things to remember. I've talked about a few of these, but One of them includes keeping our test strips in the original container. So oftentimes I actually see sometimes to compress our little packet where we store our meter or lancing device, people will take out the strips so that they're not in the little container and they're kind of floating around inside the testing kit. So those little containers are actually designed to keep out light and moisture, and they have something called a desiccant inside them that helps prevent or helps maintain the integrity of that test strip. We talked about changing our lancet regularly, ensuring that the depth is set at an appropriate level, and using the sides of our fingers. The other piece is, how do we know that our meter is giving us good results? The only way to really confirm this is to actually do what we call a lab to meter comparison. So Diabetes Canada recommends once a year taking your meter with you to the lab when you go and have blood work done, and we compare the result of either a fasting glucose or a random glucose to your test on your meter. Per our current standards of accuracy, the numbers between our lab and our meter should be no different than about 15%. So if they are, it's an easy solution in terms of speaking to your educator or your healthcare team to switch out your meter. The other thing to know too is that you shouldn't have to pay for a meter at the pharmacy. So there is a cost associated with test strips, but your meters should be free. So this is something to keep in mind as well. So how often do we check? I don't have a good answer for everyone because it will be based on your individual needs, okay? So it will depend on things like, what medications are you taking? What are your chances of having low blood sugar? We want to know how the changes you're making with respect to food or activity are impacting your blood sugar. So we might make recommendations based on those factors. But again, testing your sugar allows you to know where you are and how these things are impacting you. One way to figure out how often to test is to use this little tool here, and I'm just going to pull it up because you're able to access this on your own as well and to have that conversation with your healthcare provider about how often you should be testing. So Diabetes Canada is our current kind of repository or place we go for all things diabetes because it sets the guidelines for practice nationally. And they have these really neat interactive tools where you can plug some information in about yourself or about yourself in conjunction with your primary care provider and have a conversation around how often you should be testing. So if I fill this in here, we can do it together. Let's say I have someone with type 2 diabetes, so I'm going to hit this little bubble, and it's going to prompt me with all these questions. So we're talking about our A1C. Maybe in this case, we'll have someone with an A1C of, let's say, 8.3. So it's asking, is my patient's A1C to target? Is it less than 7? So in this case, I'll say no. And then it's going to ask me, what type of medication are we using as part of our management? So here it's distinguishing things like insulin, our insulin secretagogues, so that's things like dimicron or glyburide, other types of medication, or maybe none. So let's say, what do we want to say in this case? Which situation do we want to have? Insulin? So let's say insulin. Is your patient on an insulin pump? So for this scenario, I'm actually going to say no. Okay, so how often does your patient use insulin? Once a day? Okay, so let's say that. Oh, this is the big reveal. Okay, click here to reveal how often we should test. So essentially what this is saying is it's outlining what it thinks is our diabetes management. So this is saying we're likely using a basal insulin, a long-acting insulin once a day, and it's showing us different areas where we can test. So it's suggesting we test in the morning. It's also suggesting that on alternate days we might be interested in testing before dinner and bedtime. And this will help us determine how we need to make changes to our medication management and what's happening in our day-to-day for blood sugar control. We actually have, so you have access to this by going to guidelines.diabetes.ca, but we actually have some printed copies of the logbook where you can put down your blood sugars available for you today. Yeah. Oh, do you want to take a picture? This is your site that you want to refer to. Okay, so this is important information to know as well. What does it cost to check my blood sugar? So some of us might have private coverage. Some of us may have OHIP coverage for testing supplies, or some of us might not have any coverage at all. So if we have private coverage, great, you can have a script to submit that for an insurance claim. If you're over the age of 65 or you're on Ontario Works, ODSB, ODB, then those testing supplies will be covered based on certain criteria. But if you do not have coverage, what does it actually, what does it cost? So those test strips, the things you use to actually check your blood sugar, are between 80 cents to $1. So if we think about that, if we're having to use insulin multiple times a day, where our requirements for testing increase, maybe we're having to check 4 or 6 times, that cost can become quite burdensome in that 4 to 6 tests a day is $4 to $6 a day times 365 days a year times X number of years. So if you're only doing 1 test a year, that's approximately $365 just for the test strips. So what are our coverage options? So again, over the age of 65, private coverage, ODSB, Ontario Works, these supplies are covered. There's also a great program through Diabetes Canada known as Monitoring for Health. So if you are using insulin as part of your diabetes management, then there is some reimbursement for testing supplies per year. So it's important to know this because, again, testing can be really important for our own awareness in terms of knowing how different things impact our blood sugar. So I've just outlined here kind of the different stratifications of coverage for testing supplies based on our Ontario drug benefit or our Ontario formulary. So for instance, if you're using insulin as part of your management, you should have about coverage for approximately 3,000 test strips per year. And depending on the types of medication you're using, for instance, no medication, where the need for testing might not be as important, then our coverage for test strips or our allotment is different. Yeah. Yes, so this is already built into kind of our Ontario formulary. So they will know in terms of being able to dispense up to a certain allotment per year. Sometimes it also depends on how that prescription is written by your primary care provider in terms of how they choose to dispense, whether or not they list 1 box every 90 days. That can impact the dispensing of the test strips. Exactly. So you can ask your endocrinologist. If you don't have an endocrinologist, you can also talk to your family care provider, your primary care practitioner as well, if you are testing your blood sugars and need a script for blood glucose test strips.
Is this for only dialysis patients, or you don't have to be on dialysis?
This is anyone with diabetes. Yeah. So we've kind of covered a lot of different topics today. I actually think that this brings me to the end of my presentation. So does anyone have any questions around self-monitoring, things they need a little bit of clarification on? I would highly recommend checking out Diabetes Canada or diabetes.ca in terms of a reputable and reliable source of information. It's kind of our first place to go. The St. Mike's Hospital also has a huge repository of patient resources. And so those are reliable information sources for you to connect with as well. And if you have further questions, taking those questions back to your healthcare team. We really like when you come in with lists of questions. And sometimes people, I see some laughing, but sometimes people say, we don't have time to address questions, but we want you to write them down when you have them, so that we're able to address them when you come in. Because asking you to remember what your question was in that particular moment is hard. And then you leave and you really wanted to say, ooh, I needed to ask this question of my educator or of my team. So coming prepared with a list is actually something we really appreciate. So thank you for listening, and I hope that was informative for you today. And there are patient resources at the side, so things about hypoglycemia we talked about, hypoglycemia and driving, self-monitoring of blood glucose. There's a great tool around writing down who your healthcare team is. Sometimes it's easy to forget who is a part of your diabetes team, so all those resources are available for you there. And I think there's an evaluation being passed around, and if you could kindly complete that too, that would be great.